this platform that is actually using the camera on your phone, that is looking at facial muscle movement, right? With the mouth being open, right? The pill being on the tongue. I think you'll see this here. And when the glottis moves, that the pill has been swallowed. Your phone can do that now with your ID, right? You can unlock your phone with your face. It's already doing that. Well, can we use it? Can we use an algorithm that's already in the phone, right, for something such as medication compliance monitoring? This is that smart pill. It's a Proteus digital pill. It's a vendor out of San Francisco. I have references at the bottom to support them. But it is a small microsensor made of magnesium and copper. Do you guys ever remember in school something called the potato battery? I think I told you guys this on your visit. You wet a potato, hook it up to jumper cables, and it lights a light bulb. The entire continent of Africa is working on potato batteries. It really is. And so when this sensor that is embedded in a pill is ingested, magnesium and copper are separated by a silicone film. Gastric acid breaks down that silicone film, magnesium and copper touch. Produces a biogalvanic charge in your stomach of 1 volt. No one can feel 1 volt, just walking we're generating 8 to 10. A bandage is collecting that signal that something was ingested. That signal, that data is transferred to the cloud and transferred to their clinic or to the caregiver and patient to tell when someone took and did not take their medications. Next phase of medication compliance monitoring.
So we know that for TB medication monitoring, that would make sense. Is there an application in cardiovascular disease?
Yeah, so in TB, my colleague at UCSD is doing a randomized trial of looking at direct observed therapy versus this wireless observed therapy. So you don't have to mobilize public health workers and nurses to home to see when someone actually took their medications 2 or 3 times a day, right? And looking at costs of care. It's this technology, however much it might cost, it costs on the order of about $25 a pill, will be cheaper than mobilizing a public health worker to home. So that data should come out maybe next year after they complete their TB trial. But yeah, so hypertension monitoring, anticoagulation monitoring for atrial fibrillation, antiplatelet therapy adherence after stent placement. And I'm quoting to you high risk groups where medication non-adherence leads to an adverse outcome. Right? If this is a well-controlled hypertensive patient, I wouldn't expect that there would be a quality of care improvement other than maybe patient engagement on costs of care or outcomes. But an individual who might have just had a stroke, it may prove efficacy. Just a couple of dozen trials that have been published with this technology, but it's getting there. It requires questions and partnerships in order to see where is the best utility in such tools. So, I have an example of blood pressure monitoring now. Intermittent blood pressure monitoring, I think in 2018 now, we can largely say it should not be done anymore. At least it should not be done in the way that it always is. We need to use new tools in order to identify different risks in hypertension monitoring, but also who is at highest risk for an adverse outcome. If we look at elderly hypertension, the Medicare patient population age greater than 65, the vast predominance of them are going to have hypertension. The greater the age is, the harder it is to control the blood pressure, the greater the risk of an adverse event with polypharmacy. Using a tool such as this watch and intermittent monitoring, we can identify in this N of 1 elderly patient that this person is a nocturnal dipper. And for those of you who do hypertension monitoring or research, we know that this group can be 4 to 5 times at higher risk for strokes because it's difficult to control because of vascular tone. We didn't have a robust enough way to be able to identify this. So the technology is now offering us a new way to risk stratify patients. Again, a different way of thinking. These are piezoelectric crystals that are coming out of Stanford that are just like bandages to measure blood pressure on the horizon. Not here yet, but as we look forward, right, we'll see tools like this come to fruition. And this is what an N of 1 clinical trial looks like. This is patient care. You guys, we do this in clinic already, but our time period here on the x-axis is in days. Right? Well, in clinic, we would usually have maybe 1 or 2 blood pressure markers at 90 days, because the patient won't come in, doesn't need to come in for a blood pressure check. Well, blood pressure is measured at home and transmitted to clinics. Maybe we can adjust medications in a personalized way. Get people to target, but also watch in the horizontal arrow when we've overtreated somebody. So this N of 1 design, the personalization of healthcare through data and technology. I think Hattie showed that this smartphone EKG, which we'll see it later, but this is tertiary diagnostic. This is detecting arrhythmias and atrial fibrillation at the point of care or point of contact. And compared to Holter monitoring of 24 hours, we of course do longer monitoring, longitudinal monitoring. We will catch more arrhythmias. And we're coming up with computational models now to show, well, which patient groups do we know have atrial fibrillation, or post-CVA, or post-TIA, strokes or transient ischemic attacks. It's well known that at 6 months, there's a 15% prevalence of atrial fibrillation. How are we going to monitor people for 6 months? 5 years ago, we didn't have any technologies other than a 24 or 30-day Holter or event monitor. Now we have a $99 tool that can be used at home, capture the data longitudinally for us to better treat or identify high-risk patient populations. On the other hand, these tools can also be effective in very low-risk patient populations. I see palpitations in my clinic all the time. Right? And the first thing I go to a young person who has palpitations is, you want to buy this. And you can get it off Amazon. Give me your email, I'll give you a discount. And as soon as they see it in clinic, because we show them how to use it, it's an aha moment for a patient as well. And they know the value of it, even though they cannot interpret the EKG. They become pattern recognizers. There's an algorithm embedded in this, as you'll see, that can tell normal from possible AFib. The FDA approved the device in 2012. The FDA also approved the automated algorithm in 2015. It doesn't need a cardiologist anymore in order to detect or diagnose atrial fibrillation. So in a low-risk group that keep feeling palpitation, but it says normal, well, that can lead to less healthcare utilization. Some patients don't go to the urgent care or the ED because they're supported now. They can see their data. They know what it means, and things are normal. So it's not just high risk, it's also resource allocation for low-risk patients. So digital health and outcomes in heart failure. So as we've talked about several of those portable devices, and many of them that you've seen, we also have implantable technologies, some that you might be aware of, and we'll go through it. Sensors implanted into the heart and lungs to monitor pressure, and then new technologies. So if we look at remote monitoring and technology-enabled care for heart failure across that paradigm, okay, I'm going to put this in 2 schools of thought. Right? One is technology-enabled care, using devices at home, and that was the BEAT heart failure study. I already introduced to you guys that at 30 days and 180 days, there was no difference in readmissions and no difference in 180 days secondary endpoint of mortality. So we'll put this in the box that the technology didn't work. Right?
But which technologies didn't work?
So these were scales, blood pressure cuffs, heart rate monitors, and oximetry. And this was 1,200 patients, 600 patients who were discharged from a hospital with these tools at home, and said collect these tools at a minimum of 3 times per week. The majority of patients did it every day. So you're collecting vital signs at home in a high-risk patient population. It didn't change the outcome. So on the other side of Toronto was virtual home care. No technologies, but we're going to mobilize healthcare workers and nurses, and PAs, nutritionists, to home for a similar group of heart failure patients that are going to be discharged from the hospital. And so no technology, so high tech, and this is high touch care. And interestingly, there was no difference in readmission rates at 30 days. Right? Stayed at 20% in this Toronto healthcare network. So, of course, I would love a follow-up debate on this with this group, right? But I'll put this into the category of high touch didn't work. So high tech on one hand, high touch on the other. So is it just ineffective, or are we just not using it properly? Right? So this is out of my niece's class. You know, they want to know how to learn better. You have to know where you are and where you need to go, right? And then start filling the gap. And we know this in healthcare. So can we individualize the approach to heart failure monitoring? Back to the first slide. This is a paradigm, and even within each box, no two patients are the same. So what we did was we curated the literature on all randomized trials of mobile health or digital health devices, remote patient monitoring in heart failure. And this goes back now 12 years. It's seen in the last 5 years more trials because technologies are now more available. But in our design of about 25,000 patients, in metaregression, there is a signal for reduced mortality and reduced hospitalizations when these similar devices, blood pressure, heart rate, weight, and oximetry are used in heart failure. So we had to take a closer look at the data and say that, well, the largest trials are telling us we're not doing it effectively, right? Maybe there's the trial bias, because small trials always show greater signals than large trials. And so we started getting trial level data and started dissecting which patients and which devices. And what we found, and finding, it should be submitted by later this year, is that a heart failure group of age less than 70 derived greater benefits than the elderly group. Those with more symptomatic heart failure, NYHA class 3 to 4. Class 3 heart failure can't walk up a flight of stairs. Class 4, symptoms at rest. Compared to a class 1 patient that can go grocery shopping, can probably work, right? Remote monitoring showed more efficacy in the sicker patient population. Now, why would that be? It makes sense, right? And with your background, of course, it makes sense that they're at higher risk for an outcome, right? Therefore, our intervention might show value. Those who were admitted within the last 12 months, if a heart failure patient, they can go on years to decades without having a heart failure admission. So again, sicker patient population. The duration of monitoring is something that we thought important. We monitor people for 30 days, 6 months, 1 year, 2 years. How long? We find a high attrition at 6 months. We find its greatest benefit when it's used in the first 6 months. So maybe we should identify our resources more upfront and not rest that we're giving people devices for a year and it's going to be used effectively for that time. And finally, weight scales were the past. Our data also shows signals that you can use numerous devices. Which one of those is producing the most yield? That's probably not the question we need to ask, right? It's more related to us being able to acquire that data, analyze it, and then create treatment programs from it. So for remote patient monitoring to be successful in heart failure, and this is open to debate, that individualized approaches probably matter more than the technology itself. Okay. This is the implantable device that some of you may be familiar with. It's a wireless, battery-free, size of a dime sensor that's implanted directly into the heart and lungs that's measuring pressure. By the time the weight goes up in a heart failure patient, we're already about 1 to 2 weeks behind in their heart failure progression. That's why, even though we call them to increase their diuretic, they still end up in the hospital. So our clinic, and my director, Tom Haywood, because of him, we have one of the largest MEMS sensor programs in the United States. For those of you that can see it, it's implanted right here, or right here, at the time of a right heart cath. And this is the type of data that our nurses, this is a nurse-run sensor-based heart failure program that we've been able to develop. So nurses will monitor over the internet what's going on with this individual's pressure in their heart and lungs. If the pressure is going up, it's a signal that heart failure is progressing. This person might be at risk for an admission. But we're able to intervene, just like in blood pressure monitoring, with medication changes. This was an example of an 88-year-old woman who had 4 hospitalizations in 1 year. This group will continue to have hospitalizations until they're made palliative care. But with acquiring valid data and accurate data, it was able to at least reduce her risk of readmissions, improve her quality of life. Now we'll talk about costs of care with these types of technologies. It's very expensive. Some health insurers don't want to pay for it. It costs about $26,000 per device. So, but it's a changing, some way that we can think differently for an institution to look back and say, this person's risk is high, their cost of care is high. How can we use a tool like this?
Would you mind just maybe pointing at some of the key pieces of data and learnings there that to just help bring this important graph to life?
So this is pressure. This is pulmonary pressure, just like blood pressure. The lower the number, the lower the volume, right? The pressure in the heart. The higher this is, anything above 25 is high. That means that this person they're congested. That's the congestive heart failure, the C component to CHF. And so by adjusting diuretics, just like you would do with blood pressure to reduce systolic blood pressure, diuretics reduce this person's pressure. And so it is something we hope to achieve when weight goes down, but before even looking at weight, we're looking at pressure management.
And what does it say about hospitalizations there? Can you just talk about that one line?
So this thing here this is what the dashboard is measuring. It's all about if we input it, right? So there's always more data than you need, right? But we would follow this person clinically anyways. But the interesting thing is, once their heart failure status got better, their quality of life improved, right? The amount of follow-up that they needed was then reduced. So again, it's resource allocation. So that cost model, it's not just the upfront cost of the technology, there's many other factors that go into it. So skip over the data. And a key component in this team-based care these are not our patients, right? They're not millennials, these are our patients, right? So, what I'll show you guys is device attrition. If you take people and say that you need these devices, will you continue to use them? And I'll show you the elderly example. This is the worried well example. So promote them with health, diabetes, hypertension, glucose monitoring. And if you poll these people, and said, would you want to use these devices? 3/4 of them will say, yes, I want to use the device, for sure, I'm going to use it. But if you follow these people on, these here are study weeks, right? That there's a very rapid attrition in how people are using devices. They want to keep using it, they'll continue to say they want it. They have it, but they're not continuing to use it. Right? So how do we promote digital protection? Guys, I laughed at this technology when I first saw it, right? Because you don't need that, you just need roll of toilet paper. And we have a 1-year-old now, and that's all she needs. She does not need this, right? So first and foremost, know the individualist technology needs. We want to avoid separaria. As far as quality of care and cost of care, I introduced the whole systems demonstrator trial. 3,000 elderly patients, mean age of 78, with pulmonary disease, heart failure, diabetes, were given devices at home. A whole lot of devices, up to carbon monoxide detectors, weight scales, fall detectors, medication, MEMS caps, across the United Kingdom. And so they looked at healthcare utilization and emergency room visitations. And although they showed that there's a small 5 to 7% reduction in ED visitations, up front, there was a lot of recruitment challenges. This elderly group, there's an 80% refusal rate in technology. Granted, this was 2012 now, they probably designed a trial in 2009. Maybe this has changed. Our own data from the Pew Research Institute has showed that actually the majority of elderly individuals have smartphone technologies, but they refused enrollment, and 50% of them discontinued before before 12 months. The qualitative analysis showed that these people didn't want it. They didn't want technology to replace the face-to-face visitation. They were worried about the stigma that technology was going to label them with. Your phone is a very pleasurable experience. People ask us that all the time. Why can't healthcare be like my iPhone experience? Well, it's because you texted me and you made me feel good, right? Or someone wished me happy birthday. It's a pleasurable experience. Tech in healthcare is constantly reminding sick people that they are sick, even though it might not say it that way. Right? So, these barriers are very important for us for how we need to design, not around them. We need to design with them. So a podiatrician, low usage, and therefore we may not be able to generate the intended effects. So this is where institutes like RightCare and RAND can really start looking at behavioral science factors for how individuals engage with new technologies. Habit formation, social motivation, goal reinforcement. These are the textbook terms, right, for behavioral science. How does it apply to digital health and digital technologies? We're still in the nascent stages of understanding this. So in our last few minutes, I want to show you we've talked about technologies. I want to just introduce data and precision as it relates to heart failure. As we look at dynamic risk, we should start asking the question, can we exploit data to identify risk in a better way in populations and then in people and in individualized people? Right? Identifying somebody as high risk is not sufficient enough. Right? What is that dynamic risk? Could we have identified that risk ahead of time before it became high risk? And so those of you here who are familiar with the Framingham heart failure diagnostic criteria, this is great. This is how I learned, and when I was in school, we all learned. But this is very static. This is all based on someone has heart failure. Right? It didn't tell us a month before when they didn't have heart failure. Right? It tells us that time point is already too late. So can we use the electronic medical record and machine learning? Can we look at all these other factors that might be inside the record to help create new risk prediction tools? People might use devices already. The types of medications, the medication changes that they have, what's happening in their laboratory testing, their radiographic testing, all that data is there, as structured or unstructured as it might be. And so the concept of machine learning is you train an algorithm to create risk prediction in an established group of people who have had outcomes. And then you apply it to another group of patients to say, did my risk prediction tool work? And so when this is done, and this is in 4,500 heart failure patients with several hundred millions of data sets, what it shows is it can predict 30% of patients before 1 year of their diagnosis of heart failure. They're going on to develop heart failure, but can we look into that magic 8 ball? Can we look into the hourglass and look 1 year in advance that this might be high risk? And for no other reason than the data that's already collected. No new tools, no new method of monitoring these people. On the precision side, again, something where we need to look as these tools become more available. Don't worry about what this is. This is the single nucleotide polymorphism for BNP, brain natriuretic peptide. So it goes up in heart failure. Sure it does, right? But in different patients, it might go up for different reasons. And the therapeutic change to reduce BNP will be different in different groups. And in this group, what they've shown is you can sequence BNP, and then based on that sequencing, we can actually adjust therapies that can result in better blood pressure control and better heart failure prediction. And finally, looking at sort of on the way to new systems. This is the IBM Research Center and my colleague Professor Gupta out of West Virginia that is doing computational modeling on what's happening to heart structure. We're talking a lot about clinical heart failure, right? Signs and symptoms, medications, but there is a cellular and architectural change that's happening as heart failure is progressing? Well, we now have tools and data analytics to be able to look at those changes. Again, looking at it in a more precise way. And so what his group has done is taken a bread and butter transthoracic echocardiogram and given it to a machine learning algorithm that said, interpret it for us. Tell us what we're not seeing in it. So a cardiologist would normally be required to do all these measurements now to say what's the ejection fraction, what's going on with heart function. Well, an algorithm can do that. Right? So we're talking now, we're reaching a realm of high throughput medicine, right? Where we can get new diagnostics, but also interpret them. And as we move in these new systems, you know that whole thing, our car knows when something is going to go wrong, the check engine light. Well, yeah, in this example of heart failure or healthcare in general, right? Why can't we do that here? Right? Don't we have the tools and the data analytics to be able to do that? So in a new system of care, it's driven. There are drivers of technology and data to look at those trends in time. So what we've done, and to close up, because I love the discussion that will follow, at the American College of Cardiology, we work with a very good collaborative group to put together what does the future of cardiology and healthcare look like with digital health, big data, and precision medicine. And to do so, we put about 120 stakeholders at the ACC in DC that were from Google to payers, the AHRQ, down to innovators, healthcare administrators, insurers. I wish we put Epic in that room, and we didn't. Don't know why. But we really looked at how can we all partner in order to better understand how technologies and data are used in healthcare, and then to design the programs, right, that lead to evidence generation and sort of best practices. And you know, we've just touched the surface. You know, health innovation is all of these things, all these sequencing tools, all different types of digital health devices, virtual reality, the list goes on new ways to analyze data. But they're not one in and of themselves. I think the takeaway in this is these are all new things that are happening together. Right? So one tool, yes, but one tool is working in this paradigm. And so as we come up with a framework for new technologies, it goes from concept and product development to evidence generation. How are we going to measure outcomes? What type of guidelines are we going to come up with around best practices? So at Scripps, we have a model for technology and data. At Geisinger, they have an exceptional program around genomics and data. Those are good for these centers. How do we translate that to, across the United States for rural care, right? For border populations, for populations that we have yet to understand, the breadth of their complexities, and how do we then bring that to adoption? Healthcare administration components for how technologies and data are purchased. Right? How does it promote value from volume? And these are all the questions, and we came up with a framework in its first iteration, a framework for how we can do that together. And I'd like to emphasize that human-centric design is the key. As much as we talked about technology in our paper, highlights technology, the breadth of it is on human-centric design principles. So identifying the priority problems to solve, how do we facilitate meaningful communication and information exchange, the user, patient, caregiver, physician activation, how do we dedicate infrastructure and resources in our clinics or our healthcare systems or our insurers, and then cultural empowerment and best practices.
How do we turn it off? Thank you, Megan, for handling it. It seems maybe we have the chair of our heart failure work group is in Norway right now, and he wanted to call in because he couldn't be here. So he's actually a heart transplant recipient, and because he asked to be able to call in, we made a special exception since he was out of country. So apologies for the sound disruption.
So if there's other main takeaways, I think it would be this, right? Because we need to design and evaluate and generate, and we need to do it with similar principles, and these are just 5 of many. And then, it is what the ACC has come up with. We need to partner. There's a lot of innovation happening in our backyards. doesn't have to be LA, San Francisco, San Diego, it's happening everywhere. Right? But what are these new